Want to welcome you to another Facebook Live here on a Thursday evening. I'm coming at you from my home office here in the Twin Cities in Minnesota, and want to welcome all of you to this very special Facebook Live tonight. And we'll be talking about rethinking what it means to be at risk in nursing education. And, Keith RN, if we haven't met, my name is Keith, and as the founder of Keith RN, it's my passion to really support the needs of nurse educators by creating resources, case-based resources, and other active learning tools to strengthen how nursing is taught. So again, our students are better prepared for real-world clinical practice and the challenges that they'll face so they can successfully transition to that real-world environment. And I just want to thank all of you. For those of you who are joining us, if you're here, I would like you to give a shout out and put your name in the chat and just let us know that you're here and where you're coming from this evening. And so what we're going to be talking about tonight is a topic that I'm going to let Maria introduce. And Maria, if you want to come on and introduce both of our guests, I would like you to just have that opportunity.
Okay. Hello, everyone. I'm Maria. I am the nurse education consultant with Keith RN. And we have two special guests tonight. We have Eleonor Pusey-Reid, Dr. Eleonor Pusey-Reid, and Jeremy Lessard. And I am going to bring them on so that you guys can, here we go. Okay. Welcome, Eleonor, Jeremy. Great to have you guys here. I'm going to let you guys give more of an introduction, but I do want to recognize Eleonor. Eleonor is going to have a very busy and exciting fall because she is going to be inducted as a fellow into the NLN Academy of Nursing Education and the American Academy of Nursing. So, Eleonor, I wanted to start by saying congratulations. That's quite an honor. Eleonor, why don't you go ahead and just tell us anything else that you want the audience to know about your background, and then I'll move over to Jeremy.
Good evening, everyone, or morning, morning, Jeremy, from around the world, and everybody that's listening. We don't know where you're at, but hello, everyone. I have been teaching. I've been a nurse for over 35 years, and I've been teaching for over 30. And have had the opportunity to work with students from all type of background, and have had the opportunity to look and examine closely what we can do to help do our part in bringing students that are already accepted into programs through the program. So I would like to talk about that today and talk about some of the non-cognitive elements that sometimes we overlook as we converse and have this discussion today on Facebook. Thank you.
Okay. Awesome. And as I mentioned, we also have Jeremy Lessard, who is the founder of Level Assessments. Jeremy, welcome.
Thank you very much. And first, before I give a little bit about me, thank you, Keith and Maria, for providing a forum for us to have this discussion. I think it's an important one and should be rather engaging for all. And Eleonor, it's an absolute pleasure to meet and to spend a little bit more time with you. Again, I'm Jeremy Lessard. I'm the founder of Level Assessments. My last 20 years background has been in healthcare education technology, and more recently admissions innovation. I created Level Assessments to help programs better understand who their applicants really are beyond just GPA and test scores. And like the work that Dr. Pusey-Reid has done, she highlights several of the antecedents, and Level Assessments actually assesses for those. So we are pretty parallel in ideas about students and the antecedents. I'll kick it back over to you, Maria.
Thank you. Thank you. So to the audience, I want to just set up expectations before we get into the conversation. We really want this to be a conversation, hopefully a thought-provoking conversation. Hopefully you're going to leave with some things that you can reflect upon and do differently, and hopefully do better in your nursing programs. I also want to encourage your comments and your questions. We have a chat And please feel free to drop in any comments, any questions that you have in chat, and we will be happy to answer those. So with that, I am going to kind of set the stage. Why are we talking about at-risk students? Well, Eleanor has an article that was published, and we will put the link for you in chat. Has an article that was published in 2021 in the Journal of Professional Nursing called Creating a Culture of Success, a Framework for Addressing At-Risk Students. And I read this article and I was hit by so many things. I'm not going to give my synopsis of the article. We'll talk about these things. I think you want to hear more from Eleanor and from Jeremy and what they've had to share, because they both have done extensive research in this area. But I want to introduce the problem and why we're having this discussion. And the best way to do that is really to use Eleanor's introduction in her article. And she really talked, well, I say Eleanor, let me give your co-authors their credit as well, because she did have two co-authors, Clara Agona and Angela McDonald. So let me give them their credit as well. But in the introduction to the article, you discussed the nursing shortage, the lack of diversity in non-traditional nursing students. And you said in this article that it is important that we address the, and I'm quoting, untapped potential of nursing students to address attrition, retention, and graduation. And I think really that is a problem, a concern that we can all get on board with. We want the right students, and then we want them to be successful. And by success, we want them to complete the program, pass NCLEX, and become successful nurses. But I'm going to let you set up the stage there and talk a little bit more about the nursing shortage, the lack of diversity in non-traditional nursing students, and why that's important as we discuss at-risk students.
Thank you, Maria. Thank you, Keith, and nice to be with you, Jeremy, and this one. When we talk about creating a culture for success, we have to start with the reality of our workforce. According to the American Association of Colleges of Nursing in the U.S., baby boomers are leaving the profession because of age-related, because of their age. Compounding this is the lack of diversity that we have in our profession. The nursing workforce faces growing shortage and high attrition rates in nursing programs, and that's contributing also to the problem. Addressing the needs for untapped potential can improve the retention and help meet the workforce. Traditional at-risk labeling overlooks the systemic and dispositional factors. So one of the things that we mentioned is if we can talk about the untapped potential, because these students have untapped potential. We're going in and finding their strengths. What are they bringing? How are they getting into the program? And how are we looking at the non-cognitive elements that that these students are bringing as their characteristics? So those are the things that we want to discuss as we start out as those antecedents. The first generation student, the students, how are we measuring what resilience level and the grit level that they are coming with? What's their level of self-efficacy? What's their level of emotional intelligence? Are we looking at those elements and trying to build upon those elements and grow those elements in those students in order to really tap into those potential that they have or that we can contribute to in order for them to be successful in the program?
So you covered the problem, and then I think you went right into what at-risk means too, because that was going to be my next question, is how we define at-risk, but how we should be defining at-risk. And you kind of talked about that. And I will say that the non-academic or non-cognitive reasons for students being at risk is what really caught my attention when it came to this article. Because when we think at risk in nursing education, we think, oh, this is a student who can't cognitively do it. They have an academic issue. there are social issues, there are psychological issues, there are so many other issues that come into play. So I think the traditional label of at risk sometimes obscures the root cause of a student being at risk. So with that said, I think this is the perfect opportunity for Jeremy to jump in here, because the reason Jeremy is here is that he's tapped into that. He knows that there are a lot of non-cognitive issues that we need to assess, and we can assess them in students even before they enter the program. So Jeremy, I'm going to turn it over to you and let you talk about the work you've done in that area.
Sure. It certainly dovetails some of the work that is in Eleanor's paper there. But further upstream, if we're not measuring it, then we can't act on it. We need to assess prior to these students being admitted to programs, right? So the research shows that the beyond cognitive, I like to call them rather than the non-cognitive, beyond cognitive attributes, specifically those that are listed in Eleanor's paper, these are largely codified in individuals by early adolescence. So by the age 16 and then very early adulthood, these are codified. So it's when an applicant becomes a student, these folks, their level of self-efficacy, their grit and determination, their resilience, the way that they are going to respond under stress, those things don't change in the period 2 years. According to industrial organizational psychologists, they're not going to change in a period of 2 years. These attributes are codified. Now, there's a skill component to these that can be addressed. And then one could argue that in the 2-year span of a nursing school or a 4-year span of a nursing school, folks don't have the resources to dedicate to upskilling someone in, say, resilience or perseverance training. Where is that going to fit into curriculum? And so you've got these folks. Once they're in your doors, they're yours to work with, and that's where level assessments comes in. Level assessments does work upstream, and our role is to assess for these things prior to making an admissions decision.
Okay. Eleanor, is there anything else you want to add to that?
No.
Okay. So we have, sorry, go ahead, Jeremy.
Well, we mentioned, there are some systemic challenges here too, and there's a lack of diversity in what reflected in nursing programs. Equity doesn't necessarily equal diversity, though, right? Diversity and inclusion, I would argue strongly that those are the responsibility of the program and not necessarily that of an assessment provider, right? So psychometricians, item writers, they have always been concerned with equity. So no adverse impact by an item or by an assessment. Diversity and inclusion are the responsibility of the marketing of the school. How are you reaching those diverse populations? How are you telling them that they too have an opportunity to become a nurse?
Mm-hmm. Mm-hmm. Well, and you said a couple of things there that I want to continue talking about with you and Eleanor. Eleanor, you jump in when you want. What strikes me, one of the things that we are passionate about at Keith RN is helping clinicians become better educators. And Jeremy, you mentioned, when we're educating nursing students, we're not just educating the cognitive abilities or the cognitive skills of the students. We also we think about full professional identity of a nurse. And that includes the ethics and values. That includes professionalism. That includes things like emotional intelligence and resilience and grit. Nurses have to have those traits if they are going to be successful nurses. So if we get students in the program who maybe need to work on some of those, we have, again, clinicians who are expert clinicians, but not educators. So we have, I think, a little bit of we have a skills deficit when it comes to our educators, and then educators don't know how to do it. Let me just say that for many of us, educators don't know how to teach those characteristics because we're not educators. We, even with the belonging piece, we're not taught necessarily how to make students feel like they belong in a classroom. You know, we're nurses. We know how to nurse patients, but we don't know how to educate our students. So with that said, I think talking about the non-cognitive piece of this just really highlights the fact that we don't always have expert educators in our classrooms that can do that. And that's a problem also. Eleanor, do you have anything that you want to say about that?
I think that's why we have these platforms like this one, because it allows us to have these conversations that will bring it to the surface that we are dealing with students. The classroom has changed. When we think about educating, we always think about, this is how I was educated and this is how I'm going to do it. And not, taking that or realizing or intentionally realizing that our classroom has changed, our generation has changed. Students are experiencing and are vocalizing things that they didn't have the room to vocalize. People are coming to the classroom trauma-informed, for example, trauma-informed pedagogy and trauma-informed teaching. Students are coming to the classroom with experiences that is affecting their learning, our teaching and their learning. And if we're not aware and know how to address these, students are not going to be successful, and we're going to label them as students that are unable to make it academically because we're not recognizing, as Jeremy, I'm going to start adapting his word, beyond cognitive issues. So how do we figure out what are these elements that is characterizing our cohort, our classroom, and take that into consideration as we are teaching content, but addressing those beyond cognitive issues with our students. First generation students may not be able to comprehend 60 chapters that they have to cover in 3 weeks, but they have that resilience, they have that grit that they're bringing, they have that determination. How can I tap into that and guide them to get resources, either tutors, either a set up program? We have all, not everybody, not all the school have all the resources that we need. We have to be realistic. Not every school. There are schools that have tons of resources. There are schools that are resource limited. And the faculty is confronting these situations, and we are sitting and we're hearing and we're listening and but we don't have the tools necessary to address issues that students are bringing that are beyond cognitive, that are affecting their success, but that we need to be aware of and bring it forward to our school, to our leadership, and to our institution.
Yeah, I think he said it very well, and I think we're all on the same page here that risk is admitted into a program. It's not discovered in the course of. Sure, it reveals itself in the first semester after a couple of tests, or in that second semester when oh no, it's pathophys and it's just not making sense to these folks. But again, those risks were admitted; they weren't just discovered during the program. And faculty, the burden and their I guess empathy fatigue, we can call it, is at what I would consider a real high, because the students are presenting with, and are, as you said, Dr. Pusey-Reid, they are more vocal about their trauma and what it is that they've gone through, and they're seeking help. But we faculty don't necessarily have the resources to be able to address these things. If we are further upstream and assessing for them, though, again, as I said, if you're not measuring, you can't make an impact. I had a conversation with a nurse educator just this past week, and of course, we were talking about pre-admissions and screening and whatnot. And she said that, and I thought it was fantastic, GPA, T-scores, and prerequisite course completion are like, what'd you say, pulse, heart rate, and I forget what else she said, but she said they're basic vitals. You can't create a care plan around just those basic vitals. And you can't do it with just getting the basic things coming in with admissions either. We need to dig deeper and do a full assessment before we can diagnose and create a plan.
I like that. I've never heard that. And I was going to say that, we need to, as Eleanor said, just be truthful, be real. What we're doing right now is not working that well, right? Because we have, I think I haven't looked it up in a while. Jeremy, you or Eleanor, you may know the exact rate right now, but attrition rates in nursing schools across the country are above 30%. I talk to schools who have 50% attrition rate. So, I mean, if you're admitting students and 30 to 50% of those students are not making it through your program, then we're not doing something right. So I think we can say that what we're doing right now is not working that well. And I want us to continue, and you guys, we can finish this part of the conversation up and you say whatever you want, but I want to pose a question to the audience first. Audience, I want to ask you, how many of you look at the beyond cognitive measures when you're screening students for admissions, or is your admissions focused on GPA and prereqs and admission test scores and such? But I would love if any of you are looking. I'd love to know if any of you are looking at any of the beyond cognitive measures. Just drop it in the chat if you are, and if you are, tell us what you're looking at. Eleanor, Jeremy, before we move on from that and start talking about the at-risk label and maybe how we need to reframe it, anything that you want to add?
Untapped potential. Untapped potential students. If we look at them, that there is potential in there, there's something that they have with them that we can tap into and view, because when we say at risk, we're putting the entire onus on the student. That there is a problem and they are carrying everything, but there are environmental issues, institutional issues, and other issues that is just like in healthcare, social determinants of health. We know that 30% of what happened to you is based on your behaviors and your action. 70% is outside of your control. What Jeremy mentioned, upstream issues or middle stream issues. So the same with students. If we can tap into their potential because they are bringing a set of strengths or a set of issues that we need to figure out. And Jeremy is talking about testing, is talking about examining and assessing, so that we can discover those. And when I say we, I'm talking about not only the faculty, but the School of Nursing can figure out what are those issues and how we can work together as faculty and as school to be able to keep those students in the classroom. If they were able to get in, if they met the criteria, which is, if they didn't meet the criteria, that's another. But if they met the criteria that we have established and that the Board of Nursing from our state has determined that they came and evaluated our school is approved, and they have determined that these are legitimate criteria for admission, then if the student is admitted into the program, what can we do to address and to be aware and to tap into those students so that they are not carrying the entire onus of the issue?
Jeremy, I do want to ask you one other question before we move on. I don't know if we've named a few things, but I want to be very specific for our audience. What are some of those beyond cognitive measures that we need to be looking at that are important for success in nursing school? I know we've mentioned emotional intelligence and resilience, but name some more so that the audience can get a better picture of what we're talking about.
Yeah, it's a great question. And if you were to look closely at ONET's, the knowledge, skills, abilities, and other attributes, right? So what our federal government puts together as what a nurse needs to be successful in practice, and look at the past, it's roughly 70 years worth of research, and Eleanor's is very recent. There is a very strong correlation between those antecedents to success in a nursing program: goal orientation, critical thinking skills, the teamwork or a team focus. Resilience, we mentioned. There are, level assessments is testing or assessing for 24 of these beyond cognitive attributes. If you were to look, there's a very strong correlation between what's needed to be successful in practice and what's needed to be successful in a nursing program. Articles such as, why students drop out are there. And what Eleanor is talking about, shifting the burden of that at-risk label from the student and putting it back onto an institution and having them look, we could use the term holistic, and I'm not advocating for holistic admissions processes, but shifting some of that burden, I believe, is important, because if we mentioned the Board of Nursing says these requirements are legitimate to admit a student. If you look at the assessments that are out there, though, or what the criteria are, they strongly favor certain socioeconomic strata, and they marginalize other groups. GPA, we've got high school grade inflation, college grade inflation that we can take a look at and see that it's not a real level playing field once a student is or an applicant actually becomes a student. Lots of beyond cognitive factors as we've been talking about.
Okay. We have a comment from Laura that I'm going to throw up on the screen here. One of the biggest problems we're seeing is the lack of caring, only wanting to know what's on the test, as well as an increase in cheating.
Yeah.
Can we take care of that beforehand?
One of the things that we're measuring is that goal orientation. And what we're getting at is, what we call nursing as a calling. So are these people are your applicants, are these students able to delay gratification? Are they able to overcome adversity? What happens? What do they do when they fail that first test? Do they curl up? Do they not even bother looking at what's going to be on the test for the next time because they say, it doesn't matter if I study or not, I'm not going to get through this thing? How are they going to respond? And those who are showing nursing as a calling, right, and are strongly goal oriented, are based on the data, are getting through programs more readily and efficiently than those who do not have it as a calling. So I think those are the students that we're addressing there, those who see nursing school as a key to, or the golden ticket to the middle class, or out of whatever situation that they're in, but they don't really want to be a nurse and care for individuals.
Rafael said the overuse of AI to get answers. So kind of that same thing. Yeah. Okay. Let's, I want to talk about that at-risk label. And Eleanor, I'm going to pose this question to you, or really it's not a question, it's more of a comment. Discuss the psychological cost of that term at risk for a student.
As I mentioned before, it's putting that onus completely on the student. The student now is burdened. The student does not feel like they belong. And remember, part of all of us, we want to feel that we belong. We cannot process hardcore academic content if we don't feel valued, if we are labeled, um, or we feel that loneliness and immediately people are approaching you. I know you need extra help. I know your kind need extra testing strategies. Those are the things that immediately, if we have a small group of students in our spaces, our teaching learning spaces, and we immediately label them, we are going to lose that student. We are going to lose that student, not necessarily because they're not capable of learning, but because they're carrying psychological burden that is interfering with their success. And that's the cost.
So let's look at if we're going to reframe at risk, what I'm going to ask, what do we call a student that has some of the, whether it's cognitive or beyond cognitive? How do we identify those students without ostracizing those students and give them the assistance that they need?
Potential, untapped potential students. Now we need to go in and figure out. I have methods. Jeremy has established methods to figure out what are the strengths and viewing them from strength and not from deficit. I know that I thought med-surg and, have to be tough. I taught med-surg for over 25 years before I started to teach other courses. And I know that you have to be strict because we're going to clinicals. We have deadlines that we have to meet. But my mind has been open throughout the years. If we're not at the end of the semester, there's still hope. Because in my syllabus, it says at the end of the semester, these are the objectives that the student needs to meet. If the semester is not over, we can still meet those objectives. Now I know we have deadlines and we have schedule, and I'm smiling because I know I was in the camp for many years of, if they didn't get this at this deadline, it's over. And I have seen differently. I'm looking at things differently. If the semester is not over, there's still opportunities for you to meet these objectives. And the goal is, we have established these objectives that will help you get to where you need to. And if you're not hitting them on the specific timing that we had established in the course, but we have still not reached to the end of the semester, we can still work with you to achieve those objectives. That is learning objective or expected outcomes.
So let's talk about the cognitive deficits or cognitive risk. How do you, Eleanor, and I'm going to invite the audience as well here as Eleanor is speaking, what strategies do you use to identify a student who may be having some cognitive or academic, I'm going to call it academic, maybe having some academic issues? I hear people say all the time, I hear educators say all the time, my student's just not getting it. I'm giving it to them and they're just not able to put it together. Or they're just not getting it. So how do you identify those students who are having the academic issues? And then, what are some strategies that you use to identify and to help? And I'm going to open this up to the audience. So you guys, please drop in the chat what you guys are doing to identify your at-risk students now. And also, what strategies are you using with those at-risk students who are having academic issues?
So in nursing, we're known for using testing. So I use formative testing, things that are not going to count so strongly at the beginning, to kind of lay out and do a formative evaluation or assessment to determine, and that kind of give me a little heads up of what is coming. what is coming in the class. So you have a discussion of content. I use for many years, I use Key Unfolding Case Studies for Learning. One semester, that's all I used was unfolding case studies, inspired by Key. And I found that to be very, very helpful in building that clinical judgment that they need. So I do an assessment early on in the first few couple weeks after we start class, and that gives me a heads up of who is struggling with content, and then I meet individually with those students. And in that conversation, I explore not only the content, but I also inquire if they're open to speak, and I don't pressure them about some other issues outside that, beyond cognitive issues that could be affecting or interfering with their progress. And that will give me insight into what are some other things and that is interfering. And that helps for me to set up a plan with them. They're participating, they're in the front seat in establishing some of the things that what we can do, and tap into the resources at my institution to assist with these students. And sometimes it's nothing that the school can do. It's something that we can tap into support outside of the school, but at the institution in general, that we have those resources that the student might need to tap into those. Sometimes as simple as food insecurity, or somebody at home that they're taking care of, that they're responsible for caring, and they're trying to think about child care or elder care as the same time that they're trying to study, or they live in a household that there is just 1 or 2 bedroom for a large amount of folks. And so when I realize those things, I realize that the issue is not necessarily cognitive. The issue is beyond cognitive. And so what can we do? How can we work with these students to maybe study in the library before they go home? So those sort of things, because when I find out those beyond cognitive issues, it kind of gives insight. And then we do have services on campus that we can send them to that will help them kind of start to manage some of those issues in a practical way for them.
Talk a little bit about, okay, I thought I heard something. Talk a little bit about progressive grading and progressive learning.
So progressive grading is we're dealing, especially in adult health, pediatric, OB, we're dealing with content that are complex for students. We are expecting them to develop clinical reasoning and clinical judgment. And sometimes the first few chapters, they're not going to do well. But because everything is set up in regards to percentage the same, if the student does not do well in our initial assessment, even if they start to improve closer to the middle or the end of the semester, because they didn't do well at the start, that is pulling their average down. So progressive grading is you start with a lower percentage. Your first assessment has less percentage designated or assigned to them. And as the semester progresses, the percentage increases, because we know that folks, as they're getting it, and we can see improvement, maybe their first assessment or their first exam or their first activity, they got a 40. And then the next one, they got a 60. But all of them are equally set up to be, 20%. And that first 20% is dragging them down. So progressive grading is that you start low percentage in your assessment, even though the content is similar, but you start increasing the percentage so that at the end of the semester, when you see that the student is getting it, the light bulb is coming on, they got it, they are able to deal with some and manage and navigate the beyond cognitive issues that they're addressing. Now they're getting it, now they're putting themselves together. And so now their grade is reflecting their progress. So that's progressive grading.
Okay. I heard you explain that before, and I wanted to be sure that the audience got a chance to hear it. I think I said this to you before. It's almost, to me, it's like, I think we should give a most improved award to a student, because the student who goes from a 50 to an 80 on their exams has learned a lot more than that student that just stayed at 80 the entire time. You have those students who do the bare minimum just to get by. They're not really trying to go above and beyond. And they may have higher grades, but that doesn't reflect their learning, because you had that student who struggled and got better and improved. They may have the same grade, but probably did a lot more learning than the other student. So I like that progressive grading approach. And I would be curious to hear from the audience if you guys use anything like that, if you use any type of progressive grading, if you use a lot of formative assessment that maybe is not high stakes. I'd be curious to see what you guys, what the audience has to say. And I'm going to look, okay, the audience is just writing on some of the things in the chat, some of the things that they're doing in the classroom. Oh, look, Celeste says, I like this, Celeste. Celeste says, we do a Phoenix Award at our pinning for that student that has struggled and persevered. I like that. That student has built some resiliency and grit, I bet you. I like that. Yeah.
I'd argue that they were admitted with it.
Okay, sorry. They were admitted with it. But it can get stronger, right? Sure, of course it can.
There's a trait component to it that can be upskilled.
Okay.
Right? It reveals itself throughout the course.
Okay. So Eleanor mentioned the case studies, and I do want to talk about that a little bit. I want to talk about it because obviously that's what we're known for, because we have really good case studies. But I want to talk about it for this reason more so. I found as an educator that case studies were a great way to help struggling students, at-risk students who were having the issues with putting it all together, as we say, because I can't determine, when it comes, most of our tests are still multiple choice. Yes, we use alternate items. And we're even using some of the NGN case studies. But if you look at those NGN case studies, a lot of that is still multiple choice questions. It's just in a case study format. Yeah. So there's only so much information that you can get from a multiple choice test. What I like about our case studies is I can give it to a student and I can ask them open-ended questions that are in the case study. And now they have to explain to me what they're thinking. And so I can see where their thinking is right and where it's wrong. I'm able to give them much better feedback. It's more individualized. It's a better critique because I can see their thinking with open-ended questions. Plus, the thing to me is, if a student is struggling to put it all together, a multiple choice test is not going to help them put it all together, but taking care of a patient is going to help them take care of a patient. So case studies make sense in that way. So when you said, Eleanor, that you use a lot of them, I was so happy to hear that. And I would love to hear, do you use case studies with your at-risk students? I know you said you used them in class, but do you use them with at-risk students? And if so, kind of how do you use them, or what type of results have you had from using them with at-risk students?
So I use the method of universal design learning, meaning that whatever I offer to a student that is struggling, I offer to the entire class, so that everybody is seeing it, and so that one student that is untapped doesn't feel that we're doing something special or unique with them. So everybody is seen, because if it's worked for that group of students, it works for everybody, or it tends to work for everybody. Mm-hmm. So I tend to use that universal design. If I give a student an additional 5 minutes for an exam, for a quiz, I give it to the entire class. So I do understand that sometimes you're time limited, because, we tend to be content driven.
Mhm.
And we're working on that. I see people talking about the flipped classroom where people come prepared to the classroom with this particular content that you want them to be prepared, and then you can spend some time, quality time, in going through case study, building those clinical reasoning as a group. And when a student that is struggling hears other students sharing and discussing, it helps builds that knowledge, and it helps build that I can do this. My classmate is getting this. I can do this. So when you put folks in spaces where they see other people struggling and having discussions, and all their discussion are not necessarily right, but they're having those discussions and they're opening and they're exposing and putting themselves in a vulnerable situation by giving their feedback in class, and you make that a safe space where there's not judgment, but you pull from what the student is saying and address it from a strength base and not a deficit, not what they're doing wrong, but what are the things that they're doing right, pulling out those strength based teaching learning perspective. It allows a student that is struggling to realize, yes, I can put myself out there and I can be vulnerable, because this is a safe space that they're going to pull what are the strengths that I'm bringing to the table. Something I'm bringing to the table, it's going to be pulled out to acknowledge and value and show respect to what I'm contributing, even if what I'm contributing is minimal. I don't, as a faculty, I don't let them see that. I everything I try to pull out from all comments that people are saying, I try to pull out that strength that is contributing. And so that creates a safe space for everybody in the classroom, and it helps with that universal design learning space.
Okay. We've got a little over 10 minutes. And what I want to do is I want to kind of wrap up with one big question for Eleanor and for Jeremy, and then we'll open it up just to any other open Q&A. And then I want to be sure and share with you guys some of the links for resources that are in the chat now. Eleanor, you've shared a lot already, but I'm going to just say, is there anything else that you would like to share with the audience that programs can do to create a culture of success?
Safe space is important. How we address student and how we create that sense of belonging is crucial. We need to be mindful of our words. Sometimes we're living in a time that we say what comes to mind, and we're living in a culture right now where people speak without necessarily thinking, and those create those unsafe space, especially for students. There's a power dynamic going on with faculty and student, and so we need to be cognizant as faculty in clinical and in classroom spaces, because students are struggling, as we mentioned from the beginning. Students are bringing other elements into their learning space that and they're struggling. There's a lot of trauma, there's a lot of anxiety, there is first generation, there's microaggression. So we need to be cognizant of that and create those safe spaces. It's good that we talk among ourselves as faculty. When we have these discussions and talk among ourselves and support each other, and maybe reach out to Maria and say, Maria, I'm having this situation. What do you think? Get input from faculty that have been through those experiences to get feedback in how to address situation. There are people in your school that have experience in how to create those spaces that demonstrate caring and compassion and empathy. Those are things that we claim that we have in nursing, and we bring it to the bedside with our patient. We need to bring it also to the classroom and to the clinical spaces with our students in order to create those safe spaces.
Before I go to Jeremy, I'm going to share this quick story. Eleanor and I were speaking this morning, and I briefly told her that, as a child, I moved from Chicago, multicultural big city, to a small town in South Carolina that was not very multicultural. It wasn't multicultural at all. There were blacks and there were whites. And so I came in as the only Hispanic child in the school system. And it was eye-opening. I mean, I was 7, 8 years old at the time, and I think I can say now it was probably a traumatic experience. But what was interesting to me is, I'm not going to say what my age is, but I'm old. And I don't really talk about that experience. And Eleanor and I were talking about something else, and I just mentioned that. And she said to me this morning, she said, you experienced loneliness, and you were dealing with all these internal issues of not feeling like you belonged, and you probably lacked, confidence because you didn't feel like you belonged. And you were dealing with all these internal issues that none of the other students were dealing with because they didn't have to deal with it. They did belong. And I was like, I never thought about that. I mean, I told her, I said, you just deal with it. I just dealt with it. I mean, I probably came home and cried every day for like the first year that we were here, but I dealt with it. I got over it. But I've thought about that throughout the day, Eleanor, and the fact that we have students in our classrooms that are dealing with those issues that nobody else is dealing with. And if we as instructors are not educated to be able to see that and recognize that and know what to do about that, we have students who could probably make very good nurses who are not going to be successful because of those issues. So I appreciate you talking to me about that this morning and kind of opening my eyes to a new way to look at things that I had not looked at before. So I just wanted to say thank you for that. Jeremy, I kind of wanted to end with you. I mean, I know we've talked about level assessments as, being an admissions test, but also, I want to kind of give you the same question. How could we use what you bring to the table to inform advising and mentoring and early support and create a more successful program?
Yeah, certainly. I'll go back to one of the first things that I said. If we're not measuring it, we can't act on it. And any sort of meaningful intervention is going to require some insight, right? So if we're using the resources that we have, in this case, it's level assessments, and identifying what the strengths and areas of opportunity are, both cognitive and beyond cognitive, in your applicants or your students who are already in the program, and we're able to build out resources for them, then I think there's a meaningful intervention there. Right? If we can identify who is low in, say, goal orientation and grit and perseverance, but is very high in cognitive ability, that individual may really struggle if they score poorly on a test. Right? That is the individual. Hey, sure, they've got the 3.6 GPA when they got in, and they can get through on academics. Well, what happens to that individual when they don't do as well as they thought? Do they have what it takes to be able to persist in the program? We've got to be able to measure those things and identify them. So we can certainly intervene early when we have that information, and you can build a plan around it. And what level assessments does is tell you how those things are going to manifest in both a clinical and a classroom setting. And with that information, you can build a plan for a student, for each of the students that you have, if they're already in the program. And as an applicant, knowing what it is that you're bringing into the program, I think is incredibly, it's invaluable, and can largely inform an admissions decision as well. Because if we continue to do what it is that we've done, which is just GPA, standardized test scores, and prerequisites, we're going to continue to get what we've had, which is the downstream impact, faculty fatigue, empathy fatigue, burnout, high attrition rates, a existential crisis in a nursing shortage. Existential crisis means that people are dying because of this situation, right? We don't have enough of them. There's not enough care. and people are leaving the workforce as well. So we've got to assess for these things further upstream and accept what it is that we have in our program and work with who we've got in the program.
Thank you for that. Thank you both. I want to just open up again to the audience in chat. Any questions or comments that you have, please put those in the chat. I would also love to hear what your takeaway is from tonight. What was your big takeaway? What are your next steps? What can you go back and implement to hopefully improve what's going on in your program? So if you'll share that in the chat, I would appreciate it. And I want to kind of end with, we'll answer your questions as they come in the chat, but I wanted to be sure that you guys caught the link to Eleanor's article. We also have it's in the chat. We also have the link to Jeremy's website in the chat. And then I want to end by talking about several things that we have at Keith RN. Obviously, we have a Think Like a Nurse membership that has hundreds of unfolding case studies, active learning tools and templates, and faculty development. And I think, there is a link to that in the chat too, thinklikeanurse.com. I invite you to go there to learn more about that. And I also want to tell you about our free resources. Obviously, we do Facebook Lives, and that's a free resource. We also have a YouTube channel, Keith RN YouTube channel, that has lots of great information. And for those of you that are not members of the Teachers Transforming Nursing Education Facebook group, Keith, do we have a link to it? We will put a link to it in the chat, guys. But I strongly recommend that group. It is not a sales group. It is a support group for nursing educators. If you have a problem, if you want to vent, if you need help, you just put your question out, your comment out, and you are going to have people that will send you information, will answer your questions. It is a great support group, and I strongly recommend that group if you're not a member of the group already. So all of those links are in the chat. And I see Celeste's takeaway, and I think this is a good takeaway. I think that this to me is really, that was my takeaway from reading Eleanor's article, that a student may not be succeeding due to a cognitive issue, but a social or personal issue. I think we always think of at risk as it being cognitive or academic, and so many times, I think more so than not, it's not an academic issue. So thanks for that, Celeste. Okay, I'm going to be, Celeste says best support group ever. I assume she's talking about that Teachers Transforming Nursing Education. Okay. Keith, would you like to come back on? Is there anything you'd like to end with? We can't hear you.
Yeah, there we go. Yeah, no, I just want to say thank you to Eleanor and Jeremy for joining us tonight. This is a crucial conversation, and it's like we just kind of got started. I think, Maria, the insights that you brought from your story, I think it's like we need to look at our students differently. And I think, and we need to kind of, I really love what Eleanor said about that empathy, that we need to demonstrate that empathy, that we want our students to demonstrate that they struggle. And, that role modeling example, and our caring, our empathy, our understanding, our getting into their lived experience, especially if they're from a different culture, different country, and what that must be like. We've got to kind of, I think, do a better job of kind of understanding that, so that we can be as effective and support them, so that, you're right, Maria, they can be successful and have a wonderful career as a professional nurse, and not to sabotage that inadvertently. So those are my takeaways, and just listening to this conversation. So I just again want to say thank you for their time and their contributions to this conversation. And I commend the links in the chat to learn more about what they all offer in their resources, as well as Keith RN. So thank you, Maria, for leading this time together.
Well, thank you all. Thank you again, Jeremy and Eleanor, especially being up in the middle of the night, Jeremy. We appreciate it. Thank you to all the audience for joining us. And if you have any questions or comments for me, if you need anything more with the Keith RN resources, contact me at maria@keithrn.com, maria@keithrn.com. Thanks again, everybody, and good night.
Thank you all. Good night.
Good night.